Why does one kid's snack turn into another kid's emergency? Why do some kids outgrow allergies while others do not? I'm Dr. J. Rutland, and today on the Health Exchange, we're diving into one of the most common and often most misunderstood health issues, allergies. For this conversation, we're joined by my friend, Dr. Malika Gupta, dual board certified in allergy, immunology, and pediatrics. Together, we'll unpack what every parent needs to know to keep their kids safe and thriving. Let's get into it. Dr. Gupta, or Malika, every expert, like you, has a story, and I want to start with the journey. I don't think I've actually ever asked you that. I mean, I know your dad is a big allergist, but what drew you to allergies and why?
It's a good question. So I didn't want to be a doctor. I wanted to be a firefighter.
You're like 4'8".
I know. When I figured out that that wasn't going to work out, that whole med school thing happened. My dad has been my biggest inspiration, but the next biggest would be my daughter. So she is what you would call an allergic nightmare and was from like basically birth. Every difficult first time mom experience that you'd have with an allergic kid, that was my life right at the beginning. So she taught me a lot. I guess what I learned the most is that allergies are deeply personal and they impact daily life like in every possible way. And it's not just the person who has the allergies, but it's going to be like the friend group, the family. It's everything about every day. She's been the reason that I built the practice the way I have, truly.
What was the scariest experience you've ever had with your daughter from an allergy perspective?
The scariest experience I had was actually getting a call from school the morning of the Christmas play.
How old was she?
She was 5. And the call was, "Hi, Dr. Gupta, your daughter's having an allergic reaction." So I'm thinking like she's itching or like maybe she's got asthma, right? So I'm thinking maybe it's something like that. Apparently, her dad fed her baklava for breakfast. In the baklava, there were many things, including walnuts. This is when we found out that she had severe oral allergy to walnuts. You think that you're on top of things when it's your own kid, but sometimes it's harder than you imagine. So she went from a pollen allergy to an oral allergy syndrome, had lip swelling, throat swelling, and the adrenaline auto-injector at the school was expired. So that was probably, that
So-
would be it.
So you pick her up.
Oh, no, she wanted to sing.
She wanted to sing. So she sang. Okay.
So I showed up, we treated her. We didn't know what it was
Yeah.
at that time that she ate. And then finally her dad came clean and said he thought it was an apple turnover.
You're speaking from your experience as a parent, speaking from your experience as a doctor. So a lot of parents are worried about their kids and allergies. Food allergies. What are the top food allergies in kids and what's actually happening in the body?
It's a good question. So the most common food allergies are peanuts, tree nuts, wheat, soy, egg, fish, shellfish. And now the cool trending one is sesame. So if you were to live in Australia or New Zealand, this is old news. Sesame has been one of their major food allergens for a very long time, and that's because of the environmental influence there. For the kids here, we're seeing more and more of it, but the reactions that we're seeing with sesame, the reason why it's getting so much attention is because they are rather severe. In terms of what's going on in the body, the best way to explain what's going on is looking at the LEAP study from 2015. So the LEAP study basically helped us to understand globally exposure at a certain point in time in children who are predisposed to allergies. So that would be kids with atopic dermatitis or moderate to severe eczema and egg allergy. Those would be the two big ones. Those kids the ones that had been exposed to peanut earlier, for example, if we're talking about one of the most feared allergens, exposed at 4 months of age and continued exposure, those kids actually did not grow up to have a sensitivity to peanuts or tree nuts. That told us that we need to show the immune system what's going on, and really, if you don't use it, you'll lose it.
Yeah, it's a fascinating point. Individuals that have eczema or atopic dermatitis, the type of inflammation that can take place in those individuals, type 2 inflammation, which we both know really well, and type 2 inflammation actually leads to the production of the antibody that is responsible for a lot of allergies, right? And so what I was reading is it's actually better to expose kids orally to antigen and not through the skin because of the different immunological cascade that will get activated. You produce more IgG towards it, and that may not lead to this severe allergy that these kids get. And so, again, like you said, the LEAP study and then reading more into it, I'm just kind of like, all right, so you need to expose your children, I don't know, I guess as early as possible to some of the, at 4 months to these common food allergies so they don't have a sensitivity. So what do parents most often get wrong about food allergies?
Kind of like what you were saying. So I think a lot of people don't realize that eczema is the gateway to food allergies. It sounds weird. Why would your skin be related to food allergies at all? But it is the major gateway, and that's because of poor skin barrier. It's sort of like having a skin like barrier that looks like a mesh, maybe more than like a perfectly closed off dam. Then you've got Langerhans cells or dendritic cells that are exposed to the environment, and those guys are strong. There's lots of them. Skin's the largest organ in the body, and that is how littles become sensitized to foods. In kids who do have eczema, if you don't address the eczema, the food allergy is probably not going to get better as fast as you'd want to, or even at all.
It's such an interesting thing when you start talking about the leaky epithelium, leaky skin cells, because the same thing can happen in your GI tract, right? So in individuals that have, say, autoimmune GI tract disease, and again, the GI tract is lined by epithelial cells as well. When you have chronic inflammation there, that also predisposes kids to food sensitivity and food allergy as well. So it's super interesting to think about. And again, for those of you that don't know, the reason I really got into immunology was to be able to keep up with Malika. And I don't know, obviously, I don't know if you know this story, but it was like early on in my career in Newport, and we had met through Ryan Klein, one of my partners I share a building with. And I went to your lecture at Fleming's in Newport in Fashion Island. And you were just talking to immunology, and I was like, I need to know this better. And you don't know this, but like that night I stayed up for like 2 or 3 hours, and I was just reading about inflammation and reading and reading and reading. And it just kind of like led to more discovery in my mind and more reading. And I got obviously more into it, as you know, but it was from you. And and it was because of that lecture. Because remember, early on in our career, like I started going to the allergy conferences because of you, right? You're like, oh, you should come. And I was like, okay. So I went, and I was like, I don't know any of this stuff. And so I had to like study like a lot.
But it's related to what you do
100%.
all day long, right?
It is related. I mean, I don't feel like pulmonologists, most of them, know asthma the way that they should, because it's an allergic disease and they tend to just throw an inhaler and then.
Sometimes it is, right?
Yeah.
So there's allergic asthma, but then there's like the 31 flavors.
Because there's so many different types of asthma.
Yeah.
There's allergic asthma, there's non-allergic asthma, there's eosinophilic asthma, there's neutrophilic asthma. So many different
There's
types.
LAFSMA.
What's LAFSMA? Explain LAFSMA.
LAFSMA, like asthma that happens when someone's laughing too hard. Have you not seen that?
I mean, I've seen people cough because of laughing, so I guess I have seen it. It never occurred to me to call it LAFSMA.
You're welcome.
Is there an ICD-10 number for that?
I'll have to get back to you on that.
So look, when we get back to food allergies, there's a double-blind placebo-controlled food challenge, and I know it's intense, but like For parents out there,
hmm
when they come into your office and you tell them, I'm going to do the double-blind placebo-controlled food challenge, what does that mean exactly?
To get to that point, okay, we're going to skin test because it's got the highest negative predictive value, so it's the most accurate.
Skin test.
Well,
What's the skin test? Whether you inject under the skin and
it's more like, let's see, it's nanograms of sterilized allergen on the surface of the skin, which stimulates an IgE, immediate hypersensitivity response. So you'll get a hive at the location of a positive result. If you have a negative allergy test to whatever food is in question, then you're going to check blood work. The reason you're checking blood work is not to confirm necessarily what was on skin testing, but you're looking at components. So, for example, the peanut protein's this big, it's got 9 different components to it. If there's a suspicion that there is an allergy that maybe we've outgrown, or the goal is to desensitize to a particular food, then I want to know what I'm up against. Remember, skin testing is the like what? What are you allergic to?
Mhm.
And the blood's the why.
yeah.
What's going on inside that makes me this way? So, with component testing, for example, I'm going to see, all right, this component is nice and normal and low. So that means I can progress to this challenge. This challenge is I was once allergic to this food, or maybe I didn't know if I was. I was once allergic to this food. I've done my testing. It looks like my body's not so upset about it. So let's try and eat it. Then the graded dose, like aspect of the challenge, is basically based on how your immune system is responding to an antigen,
Mm.
right? So, what we know about food allergies is quantity and timing. So, the more of the allergen in a short period of time, you're going to have a higher risk of a reaction if you're that person, right? So with the graded dose challenge, that's placebo, double-blind, placebo-controlled. We take away the psychosocial aspect of the fear from if it's a kid, the patient, and their parent. And then the person who's actually running the challenge also doesn't know what they're giving. Usually, this is in the form of like a cookie or some kind of like interesting food. It is something where we monitor very closely for immediate hypersensitivity reactions. So, we're going to look at lip swelling, we're going to look at like rashes, usually hives on the cheek. We're going to listen for cough. So, for littles, like a dry cough that's persistent that they can't shake is another way that they'll like let us know that there's a problem. We increase the amount of allergen in each dose, and each dose is spaced about 20 to 30 minutes from the previous. You have a goal dose that you want to get to, and if you get to that goal dose, that's considered with safely if that's considered a successful challenge.
But when we say double blind, that means you don't know if they're getting the antigen either because you're giving them
Correct.
several different, you're giving them a placebo and you're giving them the challenge, but you don't know which is which.
Correct. And the value of that is that there's no apprehension really on either side. For all you know, you're just eating regular chocolate or a regular cookie. And it addresses at that point, I think the most important thing for me in that point is it addresses how much attention I need to pay afterwards
Got it.
to the mental aspect of it. So if you're at the point where you're doing the food challenge, you're in a really good spot. It means that if you've been on a journey with a patient, that you've gotten them to a point where they have a very low risk of reacting to X food. Then the one thing that people forget a lot about food allergies is that there's a huge psychosocial component to it. Huge. It affects not just, again, the person with the allergy, but it's going to affect their whole circle,
Can
right?
you give me an example of what you just said? Like an example of a situation where you're like, oh my God.
The most common example would be a kid who grew up avoiding peanuts forever. Couldn't do the same things as other kids, couldn't like go to baseball games, all the things that we used to do when we were little, whose parents' lives had changed. and whose siblings' lives had changed, the organization of their kitchen. I mean, everything, right? What camps you could go to. The word peanut, the smell of a peanut, the sight of a peanut would be triggering. And that element of anxiety is not that different looking than, maybe the beginning of an anaphylaxis,
Yeah.
right?
Yeah.
And so to dissociate the food from that previous feeling when you've overcome that challenge is very, very, very hard. And I think that's the part of double blind, placebo-controlled food challenges that we don't talk about enough. Where sure, if someone's doing really well, you get them to that place where they don't know what they're eating, you don't know what you're feeding them. Then you get to, like, say, 6 grams of peanut protein, and you're like, hey, congratulations, you made it this far. They're not going to go eat a peanut.
Right.
So that second part is the most missed aspect of oral immunotherapy, food allergy therapy, and the purpose of these challenges.
The way that we were taught growing up is you get the right answer on a test and then you kind of move on. And that's like the answer on the test. Right. And it's like, that's the end of it. But that's not the end of it. Right. Socially, that's not the end of it.
No.
Right. Because you have to almost, I mean, I'm guessing that you probably have people come in your office when after they pass the double blind placebo controlled food challenge, they probably come into your office and have a bag of peanuts and just in case or something like that. I don't know if you do that, but that's my guess.
That's actually, I should make everybody carry around a bag of peanuts now. That's a great idea. You know what I actually see is kids who have been successful at challenges at potentially other offices, but the aftermath, like the follow-up, the what do I do after this? How do I manage, like, just being in a world with peanuts and
Yeah.
be okay with it? That part isn't handled, and so, I mean, it gets to a point where it's so traumatic that there's one kid I had oh my gosh, this poor kid. I asked him to every single day before he left the house to smell a jar of peanut butter.
Oh,
If you can do nothing else for
yeah.
me, because he was supposed to go home and eat like an insane amount of nuts,
Yeah.
but he doesn't like nuts. They don't taste good.
Oh,
He's been avoiding them his whole life. It triggers this like uncomfortable feeling.
anxiety. Yeah.
So even smelling the peanut butter that was a challenge.
So, from a treatment perspective for food allergy, obviously avoiding the food is a management strategy. Everybody on the planet knows that. Like if you're allergic or you're intolerant, you shouldn't eat it. But what are the other therapies that are available now?
If you don't use it, you lose it thing, like, that's probably, like, a ubiquitous phenomenon with the immune system. So, the age-old adage of "avoid, avoid, avoid" is sort of falling out of favor. So, in terms of management now, we have a lot more tools. The skin testing, that's been something that's, tried and true for a very long time,
Hmm.
gives us very specific answers. The blood testing has come a very long way. When we're looking at blood, we're looking at the other reasons that this person is actually sensitized to that food. So that could be allergic antibodies, like you were talking about earlier. It could be allergy cell numbers. Those are kind of like some simple targets, right? That we can say, all right, what do we know and what can we target to actually calm things down so we can bring these guys in? We want to switch out allergic antibodies for tolerance antibodies, the IgGs, right? And so that is called oral immunotherapy. So there are various forms of it. It is probably one of the greatest tools that we have and one of the greatest gifts you can give a food allergic person and their family. It's not easy. You have to do the math, make the decisions of like, what is the likelihood that this person's going to have an allergic reaction as I introduce things? You also want to know, can I introduce things right away or do I need to use another therapy to help calm the immune system down? So that's where something like monoclonal antibodies. Xolair, at the beginning of this year, was FDA approved for littles, which is a big deal. So, like little kids down to the age of 1 for food allergic reactions. It's FDA approved for prevention of food allergic reactions. Allergists tend to be cowboys. And so, quite honestly, most of us want to get to the root of the problem and want to free this up for people. So we will use Xolair, and we'll probably figure out a time when we can use Xolair to not just help them feel better when they're out and about, but actually to help us do oral immunotherapy.
Yeah, so just real quick, you guys, when you're thinking about the immunology of all this, right? Understand that immunology is the same kind of in every organ of the body. So when we say the word allergy, we're talking the same immunology. So you've got white blood cells, you've got neutrophils, macrophages, basophils, eosinophils, mast cells, T cells, B cells, different white blood cells. They all do something a little bit different. Now, what we're talking about here specifically is there's a cell called the plasma cell, which is a type of B cell that makes antibodies. There are 5 types of antibodies that float around your bloodstream. IgA, which has 2 subtypes, IgG, which has 4 subtypes, IgD, IgE, and IgM. When you're thinking about all this, what she's talking about is the allergic, food allergic antibody really is IgE. IgE likes to bind to cells called mast cells, cells called eosinophils, cells called basocells. These are allergic type of cells. They're all cousins, but they release molecules that lead to a lot of inflammation, a lot of cell recruitment, and cause that swelling and that allergic reaction that we're referring to. IgG, which is usually the most abundant antibody in the bloodstream for oral immunotherapy, when they take oral immunotherapy, what you're actually inducing is the production of IgG antibodies that can bind to that IgE that leads that reaction of the food allergy, right? So it binds to certain receptors on the cell that kind of bring down that response rate of IgE doing anything. And so that's what you're trying to produce. And that's why oral immunotherapy is what she's talking about as one of the therapies for food allergy. And then she said, Xolair. How does Xolair work?
So Xolair is a monoclonal antibody, meaning like a small protein that binds to the receptor that IgE, the antibody, is going to want to bind to on the surface of an eosinophil, a basophil, or a mast cell.
Yeah.
So it intercepts essentially this process and stops that cascade of happening. If you can't get the allergic antibody to park in the parking spot, then you're not going to get the explosion, the release of all the mediators. So you're stopping the reaction at a certain point. Antihistamines, right? Those are like band-aids, but what they're doing is they're working further downstream to prevent the stuff that comes out of the allergy cells from binding to receptors and causing clinical reactions. So basically, Xolair's halting or preventing a reaction in which your body is identifying you're producing IgE to a particular food protein.
Yeah. So, and for you clinicians out there, when you give Xolair and patient has an IgE level, the IgE level can actually double, but don't pay attention to that. That doesn't mean anything. It's actually supposed to do that. So just know that clinically.
It's
So
important.
it's important
Yeah.
because sometimes I'll get a consult or something from some primary care provider where an allergist gave them Xolair and their IgE is now like 700 or 800. And I'm like, well, it's supposed to do that. Patient's fine. Other pediatric allergies like environmental allergies. What do you see? What are the triggers and what diseases should we be worried about, parents?
We talked about eczema for a hot second.
You talk about pollen.
Yep. We talked about pollen, dogs,
Mhm.
mold. People love talking about mold. They love mold.
I want to get into this for a second. Yeah, like how when somebody tells you in your office, because I get it all the time, I'm having a mold reaction, I'm allergic to mold, or I'm infected with mold.
Uh-huh.
Like how do you approach that? I know you get a lot of it because
All
you're
day
in that
long.
space. Yeah.
All
What
day
do you
long.
say? What do you do?
When people come in with mold toxicity, you got to understand, like, what do they mean by that? So is it in their airway? Do they think it's in their blood? So there's infection, right? And that's bad, like
Mhm.
really bad, like probably going to be in the hospital.
Mhm.
We're not going to be talking. And then there's sensitization, right? And that's going to be an allergic response as opposed to an infection response. That's usually going to be in the lungs, the sinuses, maybe if you're super gross, like your toes. I mean, I don't know. Like you
So-
can
Listen, you guys, like mold is everywhere in the environment. It's in the soil. It likes moisture, so that's why she's saying in the toes. So if you're hot and sweaty toes all the time, like mold can kind of overgrow in that area too. That's what athlete's foot is. But mold is kind of all over the environment. You can be allergic to anything. You can be sensitive to anything. If your immune system is like, I don't like that shit, like your immune system is going to react, it's going to respond. You're going to have some inflammation, right? These things can happen. And so a lot of times we get these patients that come in and they say, oh, I have a sensitivity to mold or I'm what, and it's hard to understand not hard to understand, but it's hard to treat for several reasons. One is you got to determine if you think it's an allergy or not. If you think it's an allergy, you're going to treat the allergy with certain things. You want to rule out infection. People that are infected with mold are people that are really poor diabetics or people that don't have an immune system that can combat the presence of this mold in their airway or on their skin or whatever the case may be. So these things can happen. But then there's these individuals that have mold sensitivity. And I like you, I'm like, all right, let's try to figure this out. I will go, if they want to pay for it, I will have them get testing within their house to see what their mold levels are.
totally.
Yeah.
Oh, for sure.
And I think it's reasonable, right?
They're going to do it anyway.
Yeah.
Honestly. And so I do the same thing, and then I'll have them show me the report. And based on the report, we'll allergy test. And if there's like a commonality there, then maybe you need to do something about it.
Right. Agree. And I am the exact same way. I mean, and there are times, again, and then in the lung, there are conditions, sensitivities caused by mold. When you're running outside and you have these environmental triggers, right? We mentioned pollen, mold, pet dander.
Yep.
Tree antigen, grass.
Tree, grass, weeds. So like Back Bay would be weeds. We're in SoCal, so grass like all day, every day. And then if you golf, that's like extra, right? Other environmental things, if we're talking about the golf course, it's going to be like your glove, the golf club.
Yeah.
So that's a different type of allergy. Then there's cats. Cat dander's the smallest, stickiest, the most intense, I guess, of all the indoor allergens. If you had a cat in a house and you took the cat out, 4 months later, you'd still see little cat things floating around.
What is dander?
So it's sort of like a little bit of skin, a little bit of hair is the best way I'd describe it. Yeah, because it's not just hair.
I heard a long time ago, and it sounds like it's wrong, is that the antigen is in the mouth of the dog and not actually the dander or something.
It's actually in the butt.
It also is in the butt.
Yeah, the anal glands.
So the anal glands. What about the mouth? Because I always tell kids that are allergic to dogs, don't let them lick your face.
Yeah, totally. I mean, yeah. So mouth, anal glands, and then the coat.
So strategies for environmental allergens. If you're a person that has, I don't know, we call it seasonal allergy. During spring season when pollen's out, they're taking Zyrtec or Zysol, the enantiomer of Zyrtec, or other antihistamines. They work to a certain extent, but what are other strategies people can do?
There's oral antihistamines.
Yeah.
Then there's nasal sprays.
Yeah.
Right? Then, have you seen those nose filter things?
Yes.
So funny. It's like putting a sieve in your nose, and then it's supposed to like block block the pollen. So
block all the pollen that you inhale.
So
the
those
pollen, it's like microns in
Yep,
diameter. Yeah.
for sure. So that exists. And then there's, like the stuff that you hear about all the time, which would be HEPA filters.
Do they work?
Yeah.
I think so too. Here's a question I have. I'll see a 30-year-old and they'll come in because they're wheezing and coughing. And they'll say, oh, when I was a kid, I had asthma, but I grew out of it. Could you grow out of it? Because I say no, but you need to tell me.
Okay, you're talking about allergic asthma?
Sure, whatever. Asthma. If somebody comes to you and if they come to you with asthma symptoms and they tell you I was a kid and I grew out of it, can they grow out of asthma? That's what I'm asking you.
That person did not,
Right.
I guess is the way to explain it. But maybe that person was the person who, when they were little, they had really bad grass pollen allergy. And so when they played baseball, like that's when their asthma flared up, right? And maybe that went away because they built more IgGs against, the grass pollen allergen, right? So maybe that part went away, but the lung reactivity, like that whole part. So when they got the flu and then like 3 weeks later, they're still coughing and wheezing and they came to see you, that's still
That's the
asthma.
asthma.
Yeah.
So, like, I always just tell people, just like you said, I just say it's an environment change. If you grew up in New York and then you moved to California, right, and you didn't have any symptoms for a while, I don't know. Yeah, perhaps maybe you didn't have symptomatic asthma, but that genetic propensity to have that airway inflammation still exists.
Yes.
And so I think that that's extremely important for people to consider. From an allergic perspective, and what you just mentioned is you can naturally grow out of your allergies.
Mm-hmm.
And is that as a result of a production of the IgG antibodies? Is that what it is? Is that what
Because of me, obviously.
you're obviously fantastic at what you do?
Obviously. It is. So some people are lucky, right? They are allergic, and then there's what your immune system is supposed to do. There's like an exchange, like the IgEs to Timothy grass go down, the IgGs go up. Sweet. Puberty helps for boys. Totally. Testosterone, anti-inflammatory, that's a win.
Wait, that's interesting. I think it's a good point to kind of bring up. So in boys,
Mm-hmm.
if they have allergies
Mhm.
before they've gone through puberty and they present to you, is that one of the things you say to parents? Say, hey, listen, like they have this allergy. I think there's a chance that they'll get through it by going through puberty.
That's a good question. So the way I will answer that question is by testing first. If the testing has moderate positive results, maybe a lot of lows, then that is what I will say. If I've got huge wheals or huge hives and huge flares, I'm probably going to have to talk to them about the fact that this isn't going anywhere. But yes, it does change the nature of the conversation.
And when you see these kids with asthma, and a lot of kids have asthma, right? A lot of kids have asthma. Your daughter, my daughter has asthma.
They don't get it. I'm like, this is not good for business, dude.
Yeah, no. Let me ask you this question. So when we look at the strategy for managing asthma and say they have allergic asthma,
Mhm.
right? And we all know that certain seasons produce certain antigens.
Mhm.
But when you give somebody a diagnosis, it's like they carry that diagnosis forever, which again, I think it's important. But at the same time, I think from a therapy standpoint, there are patients where I say, hey, listen, during these months when this antigen is prevalent, and maybe before it gets prevalent, I need you to take these medicines. But after those months, when that antigen isn't around, you can kind of hold off. Do you believe in treating people like that?
No,
What do you do?
I don't believe in wearing your diagnosis.
Okay.
Because we don't have to do that anymore. We can fix things. Like we've come such a long way. We've been waiting forever for using the science that we knew in lab and applying it in the human body and like not having to go to the store and buy Claritin and Zyrtec and not having to invest in Kleenex or like, I don't know, snot rockets are still not sexy. They're never going to be sexy, ever. I would say in that person, if you're lucky enough to know that like from May to July, it's gnarly. Like I'm a mucusy, eye-watering mess,
Mm-hmm.
then fix it. And that's when we do immunotherapy, subcutaneous or sublingual, we can fix this. We can get rid of it.
I love this point. I'm going to have you explain it. So when we're talking about allergies, you guys, which is a hypersensitivity to some antigen, some molecule, whether it's tree, grass, or whatever, that can lead to you being sensitive in your airway as well. And when you're sensitive in your airway and you activate the inflammatory response, you have wheezing, you have coughing, you have mucus obstruction, you have shortness of breath. That leads to the asthma symptoms. So there's definitely a connection between allergy and asthma. What Dr. Gupta is saying is that, hey, listen, if we know exactly what's causing this allergy and what's leading to your asthma symptoms, we can do something. And then she mentioned the word immunotherapy. What is it and how does it work?
It's sort of like taking something that's scary, like jumping out of an airplane and doing it over and over again. So it doesn't bother you anymore. So the idea is we skin test you, for example. Then I know exactly what you are allergic to and how allergic you are to that pollen, for example, or that dander, anal gland, whatever you want to call it. And then I can create or have someone create a sterile, standardized, like, but tailored allergen serum for you in particular. And I can, with graded doses, inject subcutaneously, which is nice because that's where we get the 100 years of data that tells us that minimum of 3 years of showing your body everything you're allergic to in different concentrations to a max of 5 years, you can get optimal, almost cure of allergies. So this is totally fixable. Like, if you're rolling with Claritin, like, someone didn't tell you something.
That's interesting because when I think about that, and again, I don't know the literature exactly, but I think about antihistamines over a long period of time, and there might be a link to certain diseases in the future, like, people who have Alzheimer's or have
Oh,
dementia. There's
absolutely.
like might be a link, and I'm a guy that takes Zyrtec like twice a day.
I'm gonna pretend like I didn't hear
I
that.
know.
Seriously?
Seriously, yeah, I take it like twice a day during like the spring.
What is
know.
wrong with you?
I don't know.
You can just
And then when I go to certain soccer tournaments, like if I'm going to Temecula to that field, I take a prednisone in the morning
I
because I
cannot
I
with
know,
you.
I know.
This is ridiculous. You could give yourself your own shot. Just let me test you and make the serum. Like, you should not have this problem. This is embarrassing. I'm
This is what happens
serious.
when you bring friends on. They just
I'm
like
serious. Like, I'm so mortified that, like,
I know.
you are taking 2 Zyrtec a day.
I know. I am.
Oh my God.
With your asthma patients, what you're saying is, and you once you skin test them
Mhm.
and you expose them, you give them immunotherapy. You treat them as you should with inhalers first. No? Yes.
Yes, but inhalers get a bad rap, right? People are like, "Oh, no, I don't use that inhaler."
Yeah.
Sort of like, "No, I've never smoked in my life," or like, "I don't like chocolate," or whatever, it's sort of like almost like a guilty, not pleasure, but people are really embarrassed to say that they use inhalers. But yes, it's usually after we've figured out that people are not well controlled.
You give inhalers, you treat them differently than me, and you're treating them smarter than I am because you're testing them specifically for these antigens,
Yeah.
right, that they're allergic to, and then you give them immunotherapy based on whatever it is.
Mhm.
Can you get them off of their inhaler? Is their asthma cured?
If someone's still on an inhaler, I haven't done my job.
Wow, that's very interesting.
So, like with biologics, you're supposed to, the way that they are approved, they should be used in conjunction with a long acting or a maintenance inhaler.
Yeah.
Most people will disagree with me, but the way I feel about it is that if you get to the source of the problem, then you don't need all the other like stuff, maybe unless you get sick.
I mean, but again, it takes a minimum of 3, a maximum of 5 years. So 3
Right.
to 5 years.
Yeah.
So you need 3 to 5 years of these allergy shots. And again, you guys, when we say immunotherapy, that's allergy shots, just so you know. So when you get 3 to 5 years of allergy shots as you're building up tolerance to this antigen, you may need to use supplemental therapies like inhalers and biologics.
Absolutely.
But after 3 to 5 years, you may not need any of those things. That's really interesting. I don't think anybody's ever going to do that study.
No, because that's not going to put money in anyone's pocket.
I mean, you're probably right. But from a scientific perspective, this is what I always kind of thought about. What I didn't have confidence in because I hadn't read because there's no literature supporting it yet.
Because you're still taking 2 Zyrtecs a day.
Is that part of the getting off of inhalers and potentially getting off of biologics? Because the way I look at it from a healthcare cost perspective, what you are implying is you're saying if I give you 3 to 5 years of immunotherapy, I can get you off of your inhalers and your biologics, which when you look in the long run will probably reduce the cost of healthcare.
And why do we wait so long to start biologics?
Well, I mean, I think it's because of the way in which the medicines were discovered. I mean, typically what we do is the medicines that were discovered first end up being the cheapest in the long run. And so all of the guidelines and the strategies of management are based on which medicine costs the least amount of money and is the most effective. And then you graduate from there. And then you graduate to more expensive medicines, right? Because that's just history. But it's not necessarily the scientific way of managing patients.
Unfortunately, yes. And I will say, like, I will consider a win a empty med list, like only a PRN med list.
Even for those patients to say they have a fungal sensitivity.
Especially.
We're going to transition to scratch that. I'm going to ask you questions. I want to know the first thing comes to your mind. Okay?
Okay.
Okay, so scratch that. Weirdest allergy you've ever seen.
Vibrator.
Tell me about it.
Female patient, new partner, changing things up, got a new toy and got new lube, had a reaction. This was urticaria, angioedema, so hives, swelling, reproducible with sexual activity using new toy and new lube. And then we had to figure out which one it was.
And new partner.
And new partner, yeah. Let's not forget.
And so how did you test for that? What did you do?
It was one of my favorite stories. Like, I was like, this is the best day ever. It was not a heterosexual relationship at that point. I think that's why she was experimenting with different things.
Okay.
So then I had to ask questions, like,
Yeah.
does it burn? Does it itch? Does it peel? Or do you get hives? Do you get angioedema? How long does it last for? That kind of stuff. So in the end is a cholinergic form of urticaria / angioedema secondary to the vibrator.
So you had her.
We gave her some homework to do.
Okay. And you just said stop using it and it went away.
Well, she had to use one with less oomph. It was the intensity of the vibration.
Oh, wow.
So motorcycle drivers, right?
Yeah.
Like vroom vroom.
Yeah.
Or a really aggressive toothbrush.
Yeah. That's an interesting allergy. Okay. So what's the food you secretly wish no one was allergic to?
Selfishly, chocolate. Mostly because people get mad or sad. So they'll take it out right then and there. And you're like, you're allergic to cacao.
Yeah.
What does that mean? Chocolate? Oh my God. Yeah, it's not pretty. It's not pretty. It's really sad. Sometimes people cry. I would say in California, the second one would be avocado because we're all weird avocado freaks over here. Those are the two things people cry about.
Is a hypoallergenic dog a myth?
Yeah, I'm sorry.
100%. Explain why it's a myth.
The amount of allergen per dog is what determines the allergenicity of that dog. So you could have a dog with less business happening, right? So
Yeah.
dander, saliva, glands, right? You'd have a dog with who starts off with less allergen, but if that dog is dirty, you haven't washed that dog in a month,
Yeah.
you're sort of right back where you started.
What's worse, ragweed season or peanut allergy?
Well, ragweeds taste bad, but they won't send you to the ER. So probably peanut.
Biggest food allergy myth you hear all the time?
God, there's so many.
Give me 3 then.
Okay. Someone has asked me, if you are allergic to fish, can I go swim in the ocean? Because there's fish. So let's just clear the air for everybody. If you are fish allergic, you can still swim in the ocean.
Hey, listen, that's a fantastic question. All right, what else?
There's a difference between intolerance and allergy. That's probably one of the most common things, right? Intolerance means I had a positive test, but I can still eat or be around whatever it is, and I'm fine. Allergy is I had a positive test, and I'm going to the ER with my peanut or my dog's butt, one of the two.
Okay.
Or both.
Go-to allergy-friendly snack in your own house.
Stepwise snacks. So stepwise snacks is actually it's what a lot of us use to help with oral immunotherapy or even food introduction for children where we have a higher index of suspicion that they might become allergic. So again, the atopic dermatitis, egg allergy kids. These snacks are essentially made in collaboration with an allergist. They're high in protein, they're organic, and they contain, either all the allergens or one in particular. There's a lot of varieties, but point is that they're really healthy, protein based. And if you have an annoying kid like I do, who won't do the things that she needs to do to free up her walnut allergy, it's a great way to not just introduce a food, but to keep showing the immune system the food. And that is like that, I will say, if like people don't get anything from this at all, the one thing that they should get is you can introduce a food at 4 months of age, but if you don't keep showing the immune system that food,
Yeah.
it's like all you've done is sensitize the patient.
If someone could only remember one rule about living with allergies, what would it be?
You don't have to live with allergies.
But again, when we're talking about allergies, though, and I love your statement of not everybody has to live with allergies, or you don't have to live with allergies. I love that. And I love that your bar is, I want you to develop the ability to not have to see me. That's a great bar to have, right?
Mhm.
But at the same time, there are life-threatening allergic reactions like anaphylaxis.
Mhm.
Before we kind of get into it, I want to know clinically, what does that look like, and what does it look like in little kids, and what should parents be worried about?
In little kids, it looks like this. Diarrhea and vomiting,
Okay.
and then lots of hives. But like usually it's this. I want to scratch something out of my tongue. It's really spicy. Or like there's something stuck in my throat and they'll do this. Or they'll do this really annoying cough where it's like they won't stop. And it's like one after the other. And you're like, dude, can you like get your kid to stop coughing? Oh, it's an allergic reaction. So those are like, those would be the most common for kids,
Yeah.
right? For grown-ups, it's a little different. So there's immediate hypersensitivity type allergy, and then there's alpha-gal. Alpha-gal is that interesting food allergy that occurs to typically red meat, usually like a burger style or hot dog, right? Something ground up where you have that severe allergic reaction 4 hours or plus afterwards, after eating the food. Most food allergic reactions will happen within 5 to 30 minutes. And then for grown-ups, it sort of looks like, what was that movie with Will Smith? Hitch,
Hitch. Yeah.
right?
Hitch.
Yeah. So like totally like a little bit itchy, or I feel a little bit hot. And then like, then they're doing this, then their lips are swelling. And then they're like, oh my God, I have hives everywhere. The cough, like the respiratory aspect of allergies, people forget a lot. So like the persistent cough or the throat clearing is something that gets missed a lot. So if you're ever like at my office and we're doing allergy shots because we should, and you cough, I'm going to be like in your room in 2 seconds,
Yeah.
because that's going to be one of those like telltale adult things that nobody pays attention to.
I've seen people start anaphylaxis in the hospital, right? And they call the ICU doc because you have to rush to the bedside. And if you think it's anaphylaxis and the patient starts coughing, I just intubate them. And so what I mean by that is I open their mouth, I put a laryngoscope in, I take a breathing tube, and I put it in their airway, because what happens is the swelling can get so big of that epiglottis or of the airway that you don't get a visual of the actual vocal cords. And if you can't get a visual of the vocal cords and you can't put an airway in, these people can die,
Yes.
right? And you want to do it before that happens, so at least you have the airway so the patient can live and get through it, right?
Yeah.
From our perspective in a clinic environment or even at home, how do you treat it when you see it?
You don't wait. Timing's everything, 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 everything. So what I do for patients that I'm seeing for severe allergic reactions is I'll actually prep them. So they go home with a kit that has something to fight an allergy in any way, shape, or form. So you've got an antihistamine, a leukotriene receptor antagonist, you'll have prednisone, right? And they will always have adrenaline,
Yeah.
whether that comes in auto-injector form or now nasal form,
Yeah.
and pretty soon sublingual form. Like that's everything.
Yeah.
Then you know that if they're dilly-dallying to get to the ER, or if they get to the ER and they're just getting Benadryl, that gap of time is everything.
And we know that time is everything, because the longer you wait, the higher the mortality. We already know that. So you want to get epinephrine as soon as possible. And we always knew that the EpiPen, which is a shot, was always scary for parents to give their kids or for teenagers to give themselves or whatever, because it was a needle. And recently, like about a year and a half ago, there's a newer medication that was approved for nasal usage, right, called Neffy, which we use for those individuals as well. And you can put that in your purse, you give it through your nose, no big deal. And there's going to be a sublingual form coming out pretty soon, very much like the Listerine.
Totally. Yes.
When you use those forms, it doesn't matter. The epinephrine's getting delivered. And that's the most important thing is if you think your child is having an anaphylaxis reaction, give them epi. There's not really a downside to it.
No, it's something you make in your body anyways, right? Adrenaline is an endogenous catecholamine. When you're giving it, you're just giving it in a concentration that's quicker, faster, right? But if you think about it, it's probably the most natural way to fight an allergic reaction.
I know the natural reaction is, oh, I've had this EpiPen for a year. It's expired. Like, odds are it's still going to be effective. Like, I get it.
There's data.
Yeah, there's data where it's still, so you still have to give it. I mean, like on planes, one of the problems with the medical kits on planes is they're not really regulated that much. And so people don't really check the medicines in the bag. And so you don't really know how long the medicines have been up there. And so, being a pulmonary critical care physician and having to like reluctantly raise my hand at times, you just got to use it. Like it was expired, but we used it. The patient was fine. I didn't have to divert the plane and we got to get to LAX safely and everyone was happy.
For sure.
But don't be worried about that. If you have it, use it or have one of us write you a prescription for Neffy and use the nasal spray and then use the Listerine, whatever. Again, we think that treating anaphylaxis as soon as you possibly can is extremely important. In your office, do you have EpiPens or do you have Neffy? You probably have Neffy.
I both.
You both.
I require every immunotherapy patient to have adrenaline just in case, because you never know. You just never know, and I would rather them be safe than sorry. The nice thing when new drugs come out is that there's a lot of help that's offered from manufacturers. So right now, if your doc writes you a Neffy, like, take it,
Yes.
right? The one thing adults do that kids don't do is they'll have this sense of impending doom. So like, when you're at the top of a roller coaster and
Yeah.
you're like, I'm going to die.
Yeah.
That's like usually how people will be like, I don't feel so good.
Right.
That's when you have to jab them if you're using a needle. You
Yeah.
have to hope that it works.
Please do not take advantage of a young person's physiology because they're so young. People have a tendency to wait so long to treat them because they don't have heart disease or they don't have lung disease or they don't have any comorbidities. Like they just have anaphylaxis. And so in that sense, what I would like people to do is like, don't take advantage of that. If you think it, give it.
If you think it, give it. That should be their hashtag for sure.
Yeah.
Same with asthma. People don't realize these things are deadly.
Asthma kills 11 people a day.
Does it really?
11.
Wow.
So you talked about immunotherapy. What about food desensitization? Is that the same thing?
Yes. So there's immunotherapy for environmental allergens, which can occur via a needle into the fat subcutaneous tissue, where then you're stimulating long-lived plasma cells in the germinal center of the lymph node. That's where you get that like long-lived immunity, right? There's also environmental drops, like allergy drops, right? Those are not FDA approved. They do make tablets for single allergens, for the most part, like dust or Timothy grass. They do not provide the lifelong immunity that you would get with a proper regimen. So there's a trade-off, but again, like giving kids shots is not fun. That's the balance there. With oral immunotherapy, the things that we have to remember are we have to eat the food. So you need your gut to see the allergen.
Yeah.
Where it gets tricky is if people have eosinophilic esophagitis, right? Or you find out that there is a food allergy propensity in someone who started environmental drops. So that's where it sort of gets tricky, but typically oral immunotherapy for food is you're just eating it.
And when you look at kind of the evolution and development of biologics, and these are molecules that inhibit certain cellular inflammatory mediators, cytokines, chemokines, cell receptors, all of that. Allergy in immunology is kind of leading this research. Is there something that you're excited for?
Oh my gosh. Yes. I mean, everything, honestly. The fact that we are finally getting to see what we've been reading about for so long, and works is fantastic. I'm really looking forward to the upcoming biologics for atopic dermatitis.
Yeah.
There's very many just around the corner. I think some of the gene therapies you
Yeah.
probably have heard of.
If we know that kids with atopic dermatitis can develop food allergy more often, we know that data is published. If you treat the atopic dermatitis aggressively as soon as possible, probably with more than topical therapies, then you're probably going to reduce the amount of food allergies. And so I think that you want to do that. I mean, I would think so,
For
right?
sure. It's just, parents will look at you like you're crazy if you're like, so let's focus on the skin. They're like, that's not why we're here,
Right,
But it's the progression of the allergic march.
right.
Starts with the skin. That's a gateway.
And again, all this really starts with inflammation, understanding systemic inflammation and where it goes to, right? We know that there's 3, probably 4, but 3 types of inflammation that are well defined: type 1, type 2, type 3. And we know that type 2 inflammation is the type of inflammation that leads to allergy. And wherever that is taking place in your body, it becomes systemic and it can tend to go towards that IgE production and the development of allergy. So if you see signs of it, you want to knock it down as soon as possible. Obviously, Malika believes that, and I think I believe it now too, I think you've convinced me, that oral immunotherapy or immunotherapy for environmental antigens deserves a place in the asthma treatment paradigm, like a permanent place. It deserves a permanent place for several reasons, and that's something that we'll have to look into over the course of time. But it is something that you see anecdotally have a very positive impact on your patients. And right now, we always like to end with a positive story. All right. We call this a positive pulse. I want to hear about, and I know you have millions of happy patients, but I want to hear about one patient that you connected with that makes you the most happy.
I like that you said that. So I will tell you that this type of practice, the practice that you just jumped into, you get to connect with everybody, huh? It's pretty awesome. The one I would mention is there's a little 8-month-old who came in. They have this baby and she is like full on, like if a peanut was thrown over there, she would I've never seen anything like that, right? So they came to see me. They saw someone else who had done a fellowship with me. So another one of my dad's fellows. And the guy was like, you've got allergies, but I'm not going to feed you anything. So anyways, long story short, this little baby who's now 14 months old, with the help of Xolair, so our anti-IgE biologic, and oral immunotherapy, just actually yesterday ate 2 full peanuts.
Oh, wow.
Mm-hmm.
And did just fine.
Yeah, she's golden. I mean, it was rad. It was rad.
Again, you guys, I know it sounds like, oh, well, she just cured a peanut allergy, but she didn't, because the kid's 8 months old. And so what she's doing is she's getting the parents comfortable and less anxious as a result of what this former allergy represented. And just imagine multiplying that by 5, 10, 15 years of anxiety and going to college and having to worry about peanuts, going to college and going to that party and, drinking a beer, and you're worried if there's peanuts in that flavor, if there's peanuts in whatever. I mean, again, for me, it's like that social aspect that you explained so well. You've taken it, you've shortened it, and you said, hey, I can do something for you. I can help you. And this is what we're going to do.
If I could pick one job on the side, it would be to be in restaurants. And when they're like, are there any allergies at the table? I just want to be like, yes, let's talk about this. You don't want to be that person, do you, for the rest of your life?
Right.
Like the modifier. I have 16 modifiers.
Oh my gosh. Appreciate Malika, Dr. Gupta coming in. Thank you so much for coming.
Thank you for coming in to do allergy shots.
I will be doing allergy shots. I'll record myself and we'll put it on an episode of Health Exchange,
Yes.
No doubt. Where can we find you?
Everywhere. So I am located in Crandall Mar. Super fun office. And if you're shopping there and you have to pee, come on in, best bathroom. Other than that, I do telehealth.
What's your Instagram or your practice Instagram?
At M like Mary, G like George, Allergy.
Thanks for watching and listening. We're on Instagram at the Health Exchange Podcast. Get us wherever you get your podcasts. We'll see you next time.